Cardiovascular examination. We will focus on the precordium properly. The first prerequisites, after that, general physical examination related to the cardiovascular system. Then inspection, palpation, auscultation, then some final tests. Okay. So we won't focus on the percussion because percussion of the chest is not clinically significant. It doesn't give us useful clinical information. We will not focus on the percussion of the chest. Okay. So for prerequisites, first we need the instruments. We have stethoscope, BP cuff, torchlight, two rulers to measure the CVP, and we also need a measuring tape. Okay. Now this patient is positioned 45 degrees from the horizontal. Okay, and exposure should be from the neck to the zit sternum. Okay, so exposure from the neck to the zit sternum and positioning should be 30 degrees propped up from the horizontal. Okay, and after the instruments and all of the prerequisites, then for the general physical examination related to the cardiovascular system, we will focus on the pallor, cyanosis, clubbing, edema. These are the things in the import examination or editorial examination that are important for the cardiovascular system. Okay, and under vitals, blood pressure, pulse, and jugular venous pressure. These three are very important. Okay, so we have talked about them previously, so we won't talk about them much here. We will move to the inspection of the precordium. Okay. So for inspection, we need to inspect from all angles and all sides. So from the right side, from the head end, from the left side, from the foot end. Okay. And we should also inspect tangentially. Okay. Why we are inspecting tangentially is to notice the fine movements and fine swellings over the chest. Okay. So exactly what we are looking for is we are looking for any deformities of the chest, like pectus excavatum or funnel shaped chest, or pectus carinatum, pigeon shaped chest, and those are the deformities of shape. Okay, next we will assess the symmetry of the chest. Okay, then we will move on to assess for swellings, any swellings present over the chest, any redness present over the chest. So under inspection, these things, shape, symmetry, redness, swelling, these things are important because they will impact the findings of the cardiovascular examination. Okay, so we need to note those points. Okay, so then we will move on to assess for any scars. If scars are present, they might be clinically significant. For example, a midline scar, sternotomy scar is present in patients who have undergone coronary artery bypass shaft for ischemic heart disease. Okay, so that is a scar typical of the surgery. Next, if the patient has a submammary or intramammary incision, then it might be due to some surgeries performed for valvular diseases like mitral valvotomy. So those are some of the scars. And if an infraclavicular scar is present, that might indicate the presence of a pacemaker. Okay. So if a pacemaker is present over the chest, then there might be a bulge due to the pacemaker. Okay. Those are the things that we need to note. Then we will also note the presence of veins, whether the veins are dilated, visible or not. In patients with superior vena cava obstruction or any obstruction of veins, the veins can be dilated and prominent visible. Okay. So then we will finally assess for the apical impulse. Okay. So we will inspect over the left lower chest tangentially to assess for the visibility of apical impulse. Sometimes it might be visible, in some patients it might not be visible. Okay. So after inspection, then we move on to the palpation. The first thing we will palpate is again the apical impulse. Okay. So apical impulse is the inferior most and lateral most palpable impulse over the left lower chest. Okay, that is the apical impulse. Okay, and how we are going to palpate it is we will spread our fingers because we want to cover as wide of a surface as possible, and then we will place our hand approximately over the position of normal apex weight. Okay, So we'll just place it over here, and our fingers should be insinuated in the intercostal spaces. Okay, just in the gaps between the ribs, there we should insinuate our fingers parallelly. Okay, so then we will try to feel for the apex beat with one of our fingers. Okay, suppose I feel the apex beat with this finger, then I will lift off the rest of the fingers, and then I will localize the apex beat with this finger. Okay, so first we are spreading our fingers, covering wide surface area. Then once we feel the apex beat, then we are localizing it with one finger. And so when we are palpating the apex beat and we can't palpate it this way, then we will ask the patient to turn leftwards. Okay. So this will bring the apex of the heart closer to the anterior chest wall. Then it will make it easier for us to palpate it. Okay. Okay. So then once we have localized the apex beat, suppose I spread my fingers and then I lift off the rest of the fingers and I localize it with one of my fingers, then I will need to locate the exact position of this apex beat. Okay, so I will palpate with my left hand the sternal angle, and then the second rib, just inferior to the second rib with the second intercostal space, then third intercostal space, fourth intercostal space, and then the fifth intercostal space. So this one is located in the fifth intercostal space. And then next I will use a measuring tape to measure the distance of the apex beat from the midline. Okay, so I will measure the distance. So it is about 12 centimeters from the midline. Okay, so now I have located the apex beat exactly. Okay, and in some conditions apex beat might not be present if the patient has a thick layer of fat over there, if the patient is obese, if the patient is very muscular, or if the patient has fluid in the pericardium, pericardial diffusion, fluid in the liver space, pleural diffusion, pneumothorax. So these are some conditions where apex beat might not be palpable. Okay, and then once we have determined the presence of apex beat, then we have talked about the location of the apex beat. Then we will talk about the size of the apex beat. Okay, so sometimes the apex beat is palpable with just one finger. It is the diameter of the apex beat is just one finger breadth wide. Sometimes it is wider. Sometimes the apex beat is diffuse. Okay, if the apex beat is felt over a diffuse area more than 3 centimeters in diameter, then it might indicate the presence of left ventricular hypertrophy or left ventricular dilatation. Okay, so these are the causes where the apex beat is spread over a wide area. Okay, so then there are some typical characters of apex beat. Okay, so we will talk about 4 of them. The first one is tapping apex beat. Okay, so when we palpate the apex beat, if the apex beat just hits on your finger, taps on your fingers and then goes away, that character is known as the tapping apex beat. It is classically seen in patients with mitral stenosis, and it is due to the palpable first R sound. Okay, so the tapping apex beat is due to the palpable first R sound. The R sound which is audible during auscultation, if it is very loud, then it is palpable as well, and that will lead to a tapping apex beat. Okay. So next one is hyperdynamic apex beat. Okay, so this one is a forceful thrusting of the apex beat. Okay, so the apex beat is forceful, it will hit on your fingers, but it is ill sustained. So the force will not last for very long. It will last for a short time. It will hit your fingers and then go away. So that one is hyperdynamic apex beat seen in hyperdynamic circulation. For example, aortic regurgitation. So in aortic regurgitation, the circulation is hyperdynamic, that will lead to hyperdynamic apex beat. Okay. Next one is healing apex beat. So in this one, again the apex beat is forceful, but it is sustained. Okay. So sustained and forceful will lead to a healing apex beat. It is seen in left ventricular hypertrophy. Okay. Maybe due to aortic stenosis. Any cause that leads to left ventricular hypertrophy will lead to healing type of apex beat. Okay, and this one is sustained for a long time. It's classically said that it lasts for more than 2/3 of the systole phase. More than 2/3 of systole phase, then it is healing. If less than 2/3 of systole, then it is hyperdynamic. Double apex beat से Double FX beat is classically seen in patients with hypertrophic cardiomyopathy, and the first FX beat is the one which is usually felt due to the movement of the ventricles and impact on the anterior chest wall. That is the first beat. Second one is due to palpable fourth heart sound. Okay, in hypertrophic cardiomyopathy, you will listen the fourth heart sound, and if the fourth heart sound is very loud, then it can be felt as well. That will lead to a double FX beat during a single systole or single contraction of the heart. Okay, so that is double FX beat. So these four are the important ones, important characters of FX beat. Okay, so next we will feel for any pulsations. Okay, so to feel for pulsations, we will first palpate over the four areas of the heart. The first area is the mitral area. The mitral area is the same point as the apex beat. So we have already palpated the mitral area. Next one is tricuspid area. Okay, so the tricuspid area is in the left fourth intercostal space, just lateral to the sternum. Okay, so we will palpate the sternal angle again, second rib, second intercostal space, third intercostal space, and then the fourth intercostal space. And then with one or two fingers, we will palpate for palpable heart sounds. Okay, so this we are palpating for palpable heart sounds. Next, we will move to the pulmonary area in the left second intercostal space. In the pulmonary area, we are again palpating for palpable heart sounds. Okay, and then the right second intercostal space in the aortic area for palpable heart sound. Okay, so now we have palpated all over the precordium for the palpable heart sounds. Then we will palpate over the epigastric area. Okay, we are going to use three fingers to palpate over the epigastric area for pulsations, epigastric pulsations. Okay, and classically what is said is, if you feel the pulsations with the index finger or the rightmost finger, then it is due to hepatic pulsation. Hepatic pulsation due to tricuspid regurgitation. Okay, and then if you feel the pulsation with the middle finger, it is due to abdominal aortic aneurysm. And if you feel it with your ring finger, then it is due to right ventricular hypertrophy. Okay, so those three are the main important causes of epigastric pulsations, and which part of your fingers feels the pulsation most will help you to differentiate the cause clinically. Okay, so those are all about pulsations and palpable heart sounds. Then we will palpate for thrills. Okay, so thrills are palpable murmurs due to turbulent flow of blood through the valves. Okay, and we will use our base of our fingers. Okay, so the base of our fingers will be used to palpate the thrills. Okay, we just use the pulp of our fingers to palpate for apex beat as well as the pulsation as well as the palpable heart sounds. Now we will use the base of our fingers to palpate for thrills. Again we will palpate at the same four areas of the heart. Okay, so here for the mitral area, okay, wherever the apex beat was present, that is the mitral area. Okay, so we are palpating at the mitral area, then the tricuspid area, then the pulmonary area, and then the aortic area. Okay, so we palpated for thrills. Okay, then next for right ventricular eve. For eve, we are going to use the base of our hand. Okay, or the base of our palm. So we are going to place the base of our palm just over the left sternal border, lower left sternal border. Okay, so we can palpate it like this, and we are going to check for heaving, right ventricular heaving, and if heaving is present, our hand will be lifted up. Okay, so this is how we check for heaving. Okay, so now with this, palpation is complete. Okay, so next we move on to the auscultation. Okay, so for auscultation, we will again auscultate at the four areas. The mitral area where the apex beat was present. Okay, wherever the apex beat was present, that is the mitral area. Usually it is present Usually it is present in the fifth intercostal space, just medial to the midclavicular line or over the midclavicular line. But it might be different in different people. Okay, so after the mitral area, then again the tricuspid, pulmonary, and aortic area. These four areas are where we will auscultate. Okay, and we are going to listen for heart sounds S1, S2, S3, S4. Those are the heart sounds. Then we are going to listen for murmurs, okay, and then we are going to listen for pericardial drops, friction drops, okay. Those are present in patients with pericardial pathologies, so we will also listen for them. And there are also sounds known as snaps and clicks. These are due to abnormal opening of the heart walls in certain pathologies. Those are not very important for you right now, but just get familiar with the names, okay. So clicks and snaps. Those are all of the sounds that we hear during auscultation, okay. So now the sequence of auscultation is, first we will auscultate with the diaphragm, okay. So, and using the diaphragm we will auscultate sequentially, first at the mitral area, tricuspid, pulmonary, aortic, okay. And simultaneously we will also feel the carotid pulse, because this will help us to time the murmur if the murmur is present, okay. And next, after we listen with the diaphragm, then we are going to use the bell. Again, for the bell we are going to listen at the mitral area and then the tricuspid area, okay. So most of these sounds we will hear with the diaphragm, okay. Whatever sounds we talked about, most of them we will hear with the diaphragm. But some low-pitched sounds, okay, some low-pitched sounds like the sounds of mitral stenosis, murmur of mitral stenosis, murmur of tricuspid stenosis, and S3 and S4 heart sounds, okay. These are the main sounds that we are going to listen for with the bell. So it is enough if we listen over the mitral area and the tricuspid area with the bell of the diaphragm, okay. So let me just show it to you. So we are going to check the diaphragm and then mitral area, simultaneously palpate carotid pulse, okay, and then tricuspid, and then pulmonary, aortic, and then similar we are going to palpate with the bell, then mitral, tricuspid. If we hear a murmur, then we need to describe the murmur, okay. When we describe the murmur, the first and the important thing is to note whether the murmur is present during the systole or the diastole, or we time the murmur, okay. How we do that is we palpate the carotid pulse, and along with the carotid pulse or at the same time as the carotid pulse we will hear the first heart sound, okay. So S1 comes at the same time as the carotid pulse, okay. And if the murmur is present immediately after S1, then it is systolic. If it is present between S2 and S1 or just before S1, then it is diastolic. If you listen to our sound, then it will be more clear, but we can feel the carotid pulse to time the murmur, okay. After timing, we will also need to note the character of the murmur, okay. There are typical sounds that are used to describe the murmurs, like blowing character, rumbling character, harsh quality of murmurs. So those are the terms that are used to describe the character. Then the location of the murmur, wherever we are the murmur, the mitral, tricuspid, pulmonary or aortic area, we just name the area, location, and then the radiation of the murmur, okay. So there are two important murmurs with significant radiation that you need to know. First one is mitral regurgitation. So if the patient has a murmur of mitral regurgitation that you heard over the mitral area, then the radiation of the murmur will be towards the left axilla, okay. So you also need to listen over the left axilla to check whether murmur is present, whether the murmur from the mitral area has radiated to the left axilla or not, okay. That is the first one. Second one is aortic stenosis, okay. If the patient has aortic stenosis, then the murmur will be most prominent over the aortic area, okay. Murmur will be most prominent over the aortic area, but it will radiate towards the carotid arteries. So you also need to auscultate over the necks to check for radiation of the murmur of aortic stenosis, okay. Those are the two important radiations, okay. So after the location and the radiation, then you need to describe the pitch of the murmur, whether it is high pitched or low pitched, okay. And then you also need to describe the severity or intensity. There is a grading known as Levine grading of murmurs. So you need to describe it in terms of the grading, okay, to assess the intensity. Then you also need to describe its relationship with respiration, okay. So the concept that you need to know is during expiration, the murmurs on the left side will be more intense on the left side of the heart, or the mitral murmurs or the aortic murmurs. Those two, mitral and aortic murmurs, will be more intense during expiration because more amount of blood flows to the left side of the heart during expiration. Okay, and during vice versa, similarly during inspiration, murmurs over the right side of the heart, tricuspid murmurs, pulmonary murmurs, those are accentuated or increased during inspiration. Okay, because more blood flows to the right side of the heart during inspiration. Okay, so that is about the relationship with respiration. Then positioning. So there are again two important positionings that you need to know. If you want to hear the murmur of mitral stenosis more clearly, then you will need to ask the patient to tilt towards the left side. Okay, so if you ask the patient to tilt towards the left side and then auscultate, then you will hear the murmur of mitral stenosis or MS more clearly, because the apex of the heart will lie closer to the anterior chest wall. Then, if you want to hear the murmur of aortic regurgitation more clearly, then you will want to ask the patient to sit up and then lean forwards. Okay. So if the patient sits up and then leans forward, then the left ventricular outflow tract or the aortic outflow tract, it will come closer to the anterior chest wall, and that will allow you to hear the murmur of aortic regurgitation more clearly. Okay, so those are important positions. Apart from this, there are special maneuvers. There are Valsalva maneuvers, hand grip maneuvers. Those are very complicated and not essential to know. Okay, so this much in description of murmurs is sufficient. Okay, so then we also talked about pericardial friction drops. Those are present in pericardial pathologies like pericarditis, and if it is present throughout the systole and the diastole. Pericardial friction drops, they are present throughout the systole and diastole. And how you can differentiate pericardial friction drops from pleural friction drops is you will need to ask the patient to stop breathing. Okay, when the patient stops breathing, if you still hear the sound, then it is due to the pericardial friction drop. Okay. Okay, so around this much for auscultation. Okay, then we will talk about some final steps. Okay, so first one is we need to listen for carotid roots. Okay, we need to listen over the carotid arteries one by one for carotid roots. Okay. This side and then this side. Okay. So after carotid roots, we also need to assess for hepatomegaly, because if the patient has right-sided heart failure, then that can lead to hepatomegaly. So we need to assess for hepatomegaly, whether the liver is enlarged or not. Okay. So then we will move on to the back. We can ask the patient to roll on to one side, or we can ask the patient to sit up. Okay, any one of them is fine. Okay. So over the back, again we need to inspect for any pulsations. We will inspect for the presence of any pulsations over the back. We will assess the symmetry of the back, the presence of deformities of the spine. Okay, those are important. And then what we also need to do is we need to auscultate over the lower posterior lung fields. Okay, infrascapular lung fields. We will auscultate over there, here and here. We will auscultate the breath sounds, because if the patient has left-sided heart failure, then the patient will have bilateral basal crepitations. Okay, so we need to assess for the presence or absence of bilateral basal crepitations that can be caused by left-sided heart failure. Okay. So once we do this much, then we will thank the patient and then end the examination of cardiovascular system.